regarding the history of present illness, that is characterization of the chief complaint or characterization of the symptoms. Characterizing each and every system is among the best skills that's expected from us while writing history. So always, as much as possible, we need to be familiar with characterization of each and every symptom. So as much as possible, I will try to show you the characterization of the major patient chief complaints, and we will discuss them in detail on our future bedsides under specific topics. For example, when we discuss about heart failure, we will discuss in detail how to approach a patient, or how to characterize a patient presented with shortness of breath, a patient presented with chest pain. When we discuss about pulmonary pathologies, we will discuss in detail how we take the history of cough, patient presented with cough, and the GI system of vomiting, diarrhea, or yellowish discoloration of the and the like. So for now, I will show you closely how to characterize those major chief complaints, and on the later on our future bedsides, we will see the details of those chief complaints. So let's start with pain. As you know, pain is one of the major chief complaints. That major patients seek medical attention. As you know, pain is by itself, it looks like it is something bad or something unwanted. Of course it is unwanted, but it's useful. It's useful because it will aware us, or it will tell us that something is going wrong in our body. So this is one of our body reporting mechanism for the presence of something wrong. So in pain by itself, the feeling is unpleasant, but the outcome is good. So it helps us for early reporting of the presence of tissue damage or abnormalities. So pain by itself is somehow, it has its own good side. If we say this much, let's start with defining the pain. There is an international association for the study of pain defined pain as it is unpleasant sensory and emotional experience of the patient which results from actual or potential tissue damage. So from this definition, I can understand that in the definition of pain, there is one is tissue damage. That tissue damage associated with or results in for the patient to experience emotional and sensory unpleasant feeling. So that's what pain is. So if you say pain is unpleasant sensory and emotional experience of the patient, so this pain can be acute or chronic pain. So acute pain is usually it's a physiological response to acute tissue injury, and this acute pain is usually it resolves with the removal of that noxious stimuli. For example, if you have a trauma on your hand, you will experience acute pain. If you have any fracture on your bones, or if there are any soft tissue injury, it will result in acute pain. And once that noxious stimuli is removed, then the pain will resolve. Let me give you another medical example. Our heart is one of the hard-working muscles in our body, and it's also in a continuous working till our days. So these heart muscles are in a continuous needs of oxygen and nutrients. Especially they need energy in order to generate energy. They need nutrients. So when the blood flow to this myocardium or to our heart is blocked by thrombus or atherosclerotic plaque, so it will stop blood flow to that hard-working muscles. So it will result in ischemia. Ischemia results from decreased in blood flow, decreased in oxygenation, and decrease in nutrient delivery to that muscles. If that ischemia persists, it will cause infarction or death of the myocardium. So this infarction will cause immediate chest pain. or acute pain on our chest. So these types of pain is usually called as acute pain because it is a physiologic response to acute tissue injury, and this pain resolves once that noxious stimuli is removed. When it comes to chronic pain, usually it is associated with ongoing pathology process. This is especially associated with malignancies. Malignancies usually results in chronic pain, and like diseases like rheumatoid arthritis and the like may cause chronic types of pain. By definition, chronic pain is usually a pain which lasts more than 3 months. So we have to know whether the patient is having acute or chronic pain. The other thing is if we classify pain based on the duration as acute and chronic, the other thing is based on the pathophysiology. Pain can be somatic pain, visceral pain, and there is neuropathic pain. Somatic pain is pain which arises from the dermatomal distribution of sensory nerves, and it is easily to localize the source of the pain. When it comes to visceral pain, is pain arising from our viscera or from the organs in our body. Usually these types of pain are referred to other body parts, other parts of our body based on the dermatomal distributions of the body. Usually it's what we call it a referred pain. The third one is the neuropathic pain, which results from injury to either to peripheral nervous system or central nervous system. So when there is nerve injury, the patient will experience neuropathic types of pain. It has its own quality or characterization. We will see it. So if we know this much about the pain, simply summarize the mechanism of the pain. This is just to make you familiar with pain, and we will have details of this information in the future, but for now, let me summarize with that mechanism of the pain, and we'll proceed with our main objectives. So mechanism of pain, it's straightforward. It is an interplay with central nervous system and our different receptors. Those receptors for pain are chemical chemoreceptors, which are triggered by different chemicals, by hot or cold stimuli, and the other thing is it can be from mechanical receptors and the like. So those nerve endings are stimulated by those triggering factors. So once they are stimulated, we have two pathways. One is the fastest pain pathway. This is carried by fibers called A delta fibers, and there is also a slow pain pathway. That's what we call it. It is carried by C fibers. So these fibers will carry the pain, the information to our spinal cord. On our spinal cord, there is dorsal horn, which is responsible for the sensory nerve endings, for synapsing of the sensory informations. So the first order neurons will carry the impulse to the spinal cord, and on the dorsal horn of the spinal cord there are different laminas where those fibers will synapse and transmit the information to second order neurons. So second order neurons are the spinothalamic pathways, and there is also spinoreticular pathways. They will carry the information to the thalamus. So once it reaches, to start with S. S stands for the site of the pain or the localization, as I have mentioned earlier. If you say pain, it's gross, it's broad. So we have to narrow it by localizing it. How do we localize? As I have said earlier, if it is chest pain, chest pain. If it is joint pain, we have to say joint pain. If it is abdominal pain, we have to say abdominal pain. And that localization should be further localized. For example, if I say patient came to hospital because of pain, what is your differential diagnosis? Almost everything can be your differential diagnosis. Someone may say, oh, this patient might have myocardial infarction, or he has underlying cardiac illness. And another person may say, this patient might have appendicitis. But the appendix is in the abdomen, the heart is in the thorax. If we further localize that pain, we can narrow our differential diagnosis. So if I say the patient present to hospital because of chest pain, so now the one who mentioned appendicitis as a differential diagnosis will be wrong, because I further localize the pain. The pain arises from the chest, so we should stop talking about the pathology which arises from the abdomen. So for now, I will focus on the chest. So you can mention that differential diagnosis. So you can tell me the differential diagnosis for chest pain. I will consider pathology arises from the lung. It can be from the heart, it can be from esophagus, from major vessels, or the chest wall, and the like. So this is the way I should localize the pain. If I further localize it, it will further narrow my differential diagnosis. For example, if I say left side chest pain, now I will focus on the structures which are found on the left side of the chest. So one is the heart. So my differential diagnosis will be further narrowed, like I will consider myocardial infarction, pericarditis, which is inflammation of the cardiac cushion, which is the pericardium. I will consider pulmonary embolism involving the left side of the lung. I will consider aortic dissection. So this will be among my top differential diagnosis for a patient presented with left side chest pain. So this is the major objective of localization of the pain. The next thing is the onset of the pain. As I mentioned earlier, it will tell us the duration of the pain, whether it's acute or chronic pain. Then the next thing is characterization, or the character of the pain, which is the quality of the pain. It is important. Actually, this is usually it's ambiguous. It might be a little bit confusing. So when we come to characterization or quality, when we assess the quality of the patient, different patients have different ways of expressing their pain. But there are commonly understandable expression of a patient. Like, for example, patient may say he has a crampy abdominal pain. So when we say crampy abdominal pain, usually associated with bowel obstructions, because of that peristaltic activity will cause that crampy types of abdominal pain. Patient with myocardial infarction express his pain as there is some squeezing types of pain, or feeling of an elephant sitting on their chest. So this kind of expression is used by patient with myocardial infarction. Patients with liver pathology, for example, patient with liver abscess, they will express aching types of right upper quadrant pain. Patients with gastritis or dyspepsia usually complains burning types of pain. Patients with peripheral neuropathy usually complains sharp or shooting types of pain. So if we know the quality of the pains, it will further narrow our differential diagnosis. So the third thing that we should think is the character or the quality of the pain is important. The fourth one is radiation. This is important point. Radiation is associated with, especially for visceral organs, pain arising from the abdomen, from the chest, may radiate to different body parts. For example, patients with ischemic heart disease or cardiac ischemia, usually the pain will radiate to their shoulder, to the left part of the shoulder and to the left arm. So these radiation characteristics usually is more typical for ischemic heart disease. Patients with pericarditis, usually the pain will radiate to the edge of the trapezius muscle. Patient with pancreatitis, the pain usually radiates to their back. Patient with urinary colic or stone in the kidney or with kidney stone, the pain radiates to the medial aspect of the thigh and the scrotum. Radiation is among the most important part of characterization of the pain. So if we say radiation, then the next thing is associated symptoms in addition to the pain, what the patient is experienced. For example, pain with cough, and he has also palpitation with shortness of breath. The constellation of that symptoms will lead you to a diagnosis. Don't forget that most of the patients didn't come to hospital with a single symptoms, rather they came with a constellation of symptoms. It is the job of the physician to bring those symptoms together and then reaching to the diagnosis. So we have to assess always the associated symptoms along with it. For example, patient with intestinal obstruction, they will present with abdominal pain. So that abdominal pain is associated with symptoms like vomiting, constipation, and abdominal distension. Immediately, I should consider intestinal obstruction as the cause of that abdominal pain, because I suspected this diagnosis as I consider this diagnosis it's because of the constellation of these 4 symptoms. By simply knowing that the patient is having abdominal pain, there are thousands of diseases which can cause abdominal pain. But by knowing the associated symptoms, the nausea, vomiting, the constipation, the abdominal distension, this makes me to suspect intestinal obstruction. So always associated symptoms should be described. The timing of the pain. Just it tells us whether the pain is continuous or intermittent pain, because for example patients with urinary colic or kidney stone, they will have intermittent types of pain. It's colicky types of pain because the pain arises when the stone tries to move within the lumen of the ureter. So it will have intermittent pain, so it will come and it will disappear. The other thing is exacerbating and relieving factor for the pain. Always, most of the pain have certain exacerbating and relieving factors. For example, patient with peptic ulcer, it's exacerbated by starvation or fasting, and it will be relieved by taking food. Patient with myocardial infarction, it's exacerbated by exercise and relieved by rest. Patients with pericarditis, usually it is exacerbated when they lie on their back, or when they are on sleeping position, it will be painful. But when they are on sitting position and when they lean forward, since the pericardium, the 2 layers of the pericardiums are not in contact with each other, the pain will be relieved. The other thing is patients with peritonitis. Usually they lie on their back and they will not move. That is the way they relieve their pain. Patients with nephrolithiasis or kidney stone, usually they are uncomfortable. Most they are unstable, they are in a continuous pain, and usually they don't get a comfortable position. So it's not relieved. So the last thing is the severity of the pain. Actually, it might be difficult for the patient to ask him whether it's severe or not. So usually patient says the pain is severe, but there are different objective measurements of pain, which means a scoring of pain. So patient may use that scoring system. For example, there is numerical pain scoring method that the patient will score the pain out of 10 for women who have given birth before, also vaginal birth, vaginal delivery. We can tell them that the worst pain so far experienced is labor pain. So we may tell her to compare the current pain from her labor pain, so that the patient may score the pain out of 10. Whether it's severe or not is the most important thing that we should have assessed. If it is severe on our history, we have to mention that the patient experienced severe chest pain of this duration, or severe abdominal pain and the like. And if it's not that much severe, the patient usually may not complain. So This is how we characterize pain using Socrates. Now let's take one sample history in order to understand the characterization of pain. So Mr. Muhammad, or a patient, Mr. Muhammad experienced severe sudden onset of chest pain, which is squeezing type, radiating to his left shoulder and arm of 3-hour duration. The pain is exacerbated while engaging in intense physical activity and relieved by taking rest. Associated with the pain, he has shortness of breath, cough, palpitation, and body swelling. So from this history we can clearly see that based on the point that we have raised by the abbreviation of Socrates on characterization of pain, we can see all the features of characterization of pain here. For example, the history starts with severe. It will show the severity of degree of the pain. As I have told you earlier, severity is assessed by simply by saying severe. We can know whether the patient is severe or not in general. Otherwise we may not score it. Then followed by sudden onset, so it will explain whether the onset of the pain is gradual or sudden. Then following to that, it says chest, so we localize the site of the pain is mentioned, and it says which is squeezing, so it will explain the quality of the pain. Then it will say it's radiating to his left shoulder and arm, so we explained the radiation characteristics of the pain. And lastly, 3-hour duration, which is the duration of the pain is mentioned. Then finally, exacerbation condition, exacerbated by physical activity and relieved by rest. So the pain exacerbating and relief factors are mentioned here. So finally we mentioned the associated symptoms with the pain, like the cough, the shortness of breath, palpitation, and the like. So from this sample history we can clearly understand how to write or how to characterize pain. I hope you get important pointers on how to be familiar with history taking when a patient present to you with